for my keyboard.
Yes.
Where you just away from the wall, so in case you guys have to block.
Gotcha. Yeah, because
got
I'm,
no power, whatever it is.
yeah, because that's the only
Yes.
outlet out there. Okay, thank you.
You're welcome.
Good morning, everyone. Good afternoon, everybody. As you're coming in, please mute your speakers. And we're going to go ahead and get started. So welcome to today's Lunch and Learn.
You know,
So I'm going to turn it over to Dr. Singh, and she's going to do a quick introduction and overview of SERN, and then we're going to move to the presentation.
Yes, thank you, everybody. We are so excited for you to come and participate in our Southeast Regional Genetics Network. This is our 6th year of the 7-year funding grant, so we have 1 more year. And if you are already not a member, please join our listserv. Currently, we have over 400 members in the Southeast region to get to know your colleagues and share. But also, if there are topics of interest that you want to hear about genetics in general, please send us those topics or the speakers. If there are certain speakers in your institutions who you feel are doing cutting edge work, as we are going to share with you today, how excited we are here to have Dr. Constantino, and I'm going to let Teresa introduce him formally to let you know the wonderful things he's bringing to Georgia. Has great plans about Georgia. So, Teresa.
Yeah, so before we get started, I am going to post a pretest link in chat. So if you haven't had the opportunity to take the pretest, it will be available in the chat momentarily. But I would like to introduce just a quick introduction. So if you can type in chat your institution, your company, and organization, and if you are attending in a group with multiple people, because I know some of you guys are in conference room and you're sharing a Zoom link, just put in chat how many people are in the room with you. And so that way we can just get an accurate account of who's on the call today. And so at the end, after his presentations, you'll be able to ask questions. You can do that by muting and unmuting yourself, or you can type your questions into chat as well. And we will be monitoring chat for questions. So with further ado, I would like to introduce Dr. John Constantino, who is a board certified child and adolescent psychiatrist who specializes in the diagnosis, treatment, and prevention of behavioral and mental health conditions of children and adolescents. He is the current chief of behavioral and mental health at the Children's Healthcare of Atlanta. And with this position, he seeks to innovate behavioral health practice, resolve fragmentation in the delivery of care, enhance access to interventions of proven benefit, and improve long-term mental health outcomes for children and adolescents throughout Georgia. Prior to joining Children's Healthcare of Atlanta, he served as psychiatrist in chief at St. Louis Children's Hospital, as well as the Blanche Idelson Professor of Psychiatry and Pediatrics at the Washington University School of Medicine in St. Louis, where he directed the Division of Child and Adolescent Psychiatry for the past 12 years. So Dr. Constantino, I will turn it over to you now for your presentation.
Well, thank you very much, Teresa. Let me, let's see, I will share my screen. Let's see. Here we go. Okay. All right. Well, good afternoon, everybody. It's such a pleasure to be with you all today. And my goodness, to see in the chat that that there are attendees from all over the United States and all over the world. There was one from, I thought it said Argentina that flashed through the chat, and then from Oklahoma to Children's Hospital of Philadelphia, Arizona, Kansas, and the Southeast. So thanks everyone for joining today. And the title of my presentation is behavioral health and development in individuals with medical or neurological conditions of known genetic origin. That's kind of a mouthful of a title, but I'll try to unpack that as we're going through. And I'll first show a disclosure slide. This is a picture of kind of my new home. I recently moved from Washington University in St. Louis, as Teresa pointed out, to Children's Healthcare of Atlanta and Emory University, based on a pretty unprecedented opportunity to actually deliver some of the mental health services that I'm going to talk about today to a population of children that is fully representative of the population of Metro Atlanta and the state of Georgia. And this health system is very committed to an equity-based approach to delivering mental health care on a par with medical care, which is what it should be, and mental health care on a par with medical care. And so that was part of the nature of my move here. But so many of the things I'll talk about today are, consistent threads in research and discovery, and so that will hopefully become clear as the time goes along. This is a disclosure slide, though. No industry consulting or stock equity. I receive royalties for a scale that we developed years ago, the social responsiveness scale, which is a quantitative measure of autistic traits that many of you may be familiar with. And it's been really a partnership with this test company, Western Psychological Services, that has allowed the scale to be sort of deployed at very low cost, and with translations in over 60 foreign languages, and really deployed around the world in clinical and research kinds of settings, including public health settings. And my research support, and the research support that underlies some of what I'll present today, and most of what I'll present today is work that was done by other people, but my own research support is has been from the U.S. National Institute of Child Health and Human Development, the National Institute of Mental Health, the CDC, and NCATS. So here's my outline for today. My biggest goal is to be useful to a group of people who is already consummately well educated in genetics and all things related to it. So I'm hoping that this presentation today will kind of expand horizons a little bit. But what I'll first just touch on is some of the latest data on the excess in psychopathology that is observed in identifiable genetic syndromes, and then so I'll start with that, and then we'll talk a little bit about the what we do when we identify a behavioral condition that's occurring or complicating a medical and neurologic condition of known genetic origin. And then the last part of the talk, I'll kind of cover some of the frontiers in advancing knowledge about the relationship between such rare conditions and behavioral impairment. Well, I'm going to start with what I think is one of the primers on if we didn't historically think that that there was a strong relationship between the genetic syndromes and those that we know are associated with various kinds of medical or neurologic changes and psychiatric conditions. This is the definitive study. It was published just in 2022. This is a Danish case cohort of individuals who were identified population-wide, and looking at the relationship between psychiatric conditions, excuse me, schizophrenia, bipolar disorder, major depressive disorder, autism, and ADHD, or any mental health diagnosis, as a function of the various kinds of recurrent copy number variants that are known to result in medical or neurologic syndrome. So here you can see on this particular graphic on the right, and I apologize, it's a very small table, so you have to exercise very close inspection of this. These are my two adorable grandsons. I couldn't resist but to put them in this slide. But if you look closely, you'll see the different chromosomal rearrangements. Here's 1q21.1, 15q11.2, et cetera, all the way down. And under each of those, these different mental health conditions. And what you see for most of them is that there is a clear propensity for these CNVs to increase the risk of these psychiatric syndromes that are the most common of all of the human psychiatric syndromes. And they each result in these sort of hazard ratios that are very significant and are defined by the data from this complete population capture of the Danish case cohort. So I really recommend this particular paper. It's a very significant epidemiologic advance that clarifies for these kinds of mutations what the burden for change and the likelihood. And again, these are not just the likelihood of depression and anxiety, but including diagnoses of schizophrenia, bipolar disorder, autism, and ADHD. Okay, let me make sure I can advance the slide here. Here we go. Okay, similarly, if you look at it the other way around and you ask, what are the rates for deleterious copy number variants in early psychosis versus autism spectrum disorder, they're very comparable. So these are plots of deletions and duplications that occur among individuals with early onset psychosis, autism, or control populations. And so what you can see in that plot on the left is that many of our patients with early onset psychosis are carriers of the same kinds of recurrent CNVs that have been implicated as partial contributors to the cause of autism spectrum disorder, and significantly higher than the rates for control subjects. When one looks at populations of individuals who have developmental disorders like autism that are known to have some significant proportion of causation accounted for by genetic conditions, you can look at the mental health and psychiatric, serious psychiatric problems of that population. So this is a plot of the conditions across different psychiatric conditions for the requirement for inpatient psychiatric hospitalization for patients with autism. So these are all patients with autism, and looking across these different conditions for rates for inpatient stays, and the diversity of psychiatric syndromes with which people with autism present for psychiatric admission. And again, underscoring that not only are these, conditions that are complicating a condition, but literally precipitating the precipitating cause of an inpatient crisis. Now, we also know that from a standpoint of not just rare psychiatric or rare genetic risk for these conditions. So when one thinks about deleterious variants that are resulting in medical or neurologic conditions, for the most part, these are the result of singular variants in the genome, whether inherited or de novo. One of the things that I want to point out is that it's important to know also that for some of the developmental disorders that are contributed by rare variants, the larger proportion of the manifestations of those conditions are actually caused by common variants. So it's important to state that, for example, autism spectrum disorder, even though a significant proportion of kids with autism spectrum disorder, patients with autism spectrum disorder, have identifiable single gene variants that are resulting in significant contribution to their condition, or on the basis autism being contributed by an excess of chromosomal rearrangements. The fact is that the greatest burden of population attributable risk for autism is actually inheritance. And so most of the genetic causation of autism, even though this discussion today is about rare genetic variation and medical and neurologic syndromes caused by molecular genetic variants, I want to make the point that autism is itself, and this is true for intellectual disability as well, is also a function of common genetic variation. That is a major, polygenic risk is a major player in the population burden of neurodevelopmental conditions. And the interesting thing about that burden, about that inherited burden, is that it strongly overlaps with other psychiatric conditions. And for autism, a particularly profound overlap in polygenic liability for autism is polygenic liability for ADHD. So the overlap between those two is almost 50%, which is absolutely remarkable, that the genetic underpinnings of inheritance in autism are shared almost 50% by the genetic underpinnings for inheritance in ADHD. And again, although that's not a direct line to rare psychiatric or rare neurologic and medical syndromes that are caused by, singular genetic variants, if polygenic risk has that kind of overlap, it's not too hard to infer the idea that such overlap can be a function of single gene variants. And so for autism and ADHD, just to finish this point, if you are an individual with ADHD in the population, if you're a case of having ADHD, the likelihood that autism occurs in one of your first-degree relatives in a sibling is 4.5 times higher than the general population risk, which is absolutely remarkable. So thinking about that level of overlap between those conditions, and there's other ways of estimating the overlap between autism and ADHD, that this clarifies that these have a really very much a joint kind of biology. And so when we think about that, historically, as I think most of you know, a lot of times when a child historically would have autism, they couldn't be diagnosed with ADHD and vice versa. And thank goodness we've done away with that and recognized that, of course, children with autism can have ADHD and can benefit from treatment for ADHD. But we've even gone a step further in science to take the position that these are not only sort of chance comorbidities, they are part and parcel of the causation of each other. And so the point of this is to say that the genetic causation of neurodevelopmental disorders and the genetic causation of psychiatric disorders is intricately linked in any way that you want to think about it. And what we've just gone through today, just based on a handful of papers over the last few years, looks at polygenic risk, looks at copy number variation, and looks at how these particular syndromes show this excess risk, not just of sort of common sort of stress psychopathologies, but even things as specific as schizophrenia and bipolar disorder. Whoops. And then And then here's another very recent national cohort study, one more to look at across the board, familial versus de novo genetic causes of intellectual disability. So this takes known single gene or copy number variations that are known to be associated with increased risk for intellectual disability, and asks for de novo cases and asks for familial cases with those variants. What is the excess, or what is the risk for emotional disorders of various kinds? Again, anxiety, depression, behavior disorders, hyperactivity, and so on. And here again, that you see that there is this excess risk. And interestingly, for the familial variants, the influence on psychopathology is actually higher than for the de novo variants. And one way to think about that is that for those kinds of genetic variants that are compatible with transmission across generations in families, they tend to be milder from the standpoint of the overall effect on neurodevelopment. But those that escape, the sort of severe impact on neurodevelopment and are milder and are therefore transmitted in families, show these particular kind of increases in liability towards psychiatric disorders, which is a subtle kind of paradox in thinking about, which of these variants are more profoundly affecting fundamental aspects of cognition and general development versus which ones in their milder forms are really showing these kind of pronounced effects on behavioral development. Okay, so that the first thing, if folks, when we can talk about this at the end, but if folks weren't convinced that we haven't amassed a database that at least demonstrates in principle that these particular conditions are linked, they're associated, they're causally associated, and there is disproportionate burden of psychiatric conditions across the board in this population of patients. Now, I think it's important also to think about, when you have a genetic syndrome, what are the modifiers that we know something about so far that might affect whether the phenotypic expression of that condition includes a psychiatric syndrome or not. And so we've actually learned some things about that over the last few years. So this is a really lovely study that was published in Psychological Medicine in 2021 that was a very careful look. Many of you may be familiar with it, but it's really worth a look if you haven't seen it, because it really is a very definitive kind of demonstration of what I think has become a paradigm shift in the interpretation of a genetic result. Okay, and this is a study of children with 22q11.2 deletions that are known to be de novo. So these are not familial events. These are de novo events in this group of children. And to orient you on the figure that's in front of you, if you look at, kind of tilt your head and look at this distribution, this is a sort of bell curve of intelligence scores for children with de novo 22q11.2 deletions. And what you can see, if you look closely at that, is that the mean IQ score for the children in that group is 70. And the distribution is this way. It's a shifted distribution, shifted bell curve towards the pathological end, which is what we observe among children who have these conditions, but a very wide range of outcomes. Some kids with an IQ of 100, some kids with an IQ of 40, and historically we would have said, why on earth, if you have a 22q11.2 deletion, do you end up with more or less cognitive burden associated with exactly the same chromosomal rearrangement? Well, here comes the group that published this study and asked the very important question of whether or not one could predict these outcomes on the basis of polygenic background, genetic background that doesn't relate to the mutation itself, but rather to the genetic background of the rest of your genome, essentially. And the way it was indexed in this study was essentially by compiling the mid-parental IQ of the parents of the children, and acquiring this absolutely remarkable result that the intraclass correlation coefficient between the mid-parental IQ of a child and that child's ultimate IQ, if they have a 22q11.2 deletion, is 0.54. And that's depicted by, here's the bell curve of the parents in this sample and the correspondence that if you were a parent on the upper end of the IQ distribution, that generally that corresponded with your child being on the upper end of the IQ distribution of among all of those children with 22q11.2 deletions. And if you were a parent on the lower end of the IQ distribution, and that doesn't mean that you're a parent who is abnormal, just with a somewhat lower than average IQ, but the consequence of whatever that polygenic background means and can be indexed by a parental IQ score is that the impact of that genetic background on this particular mutation is that the parallel line there puts an offspring at a very high risk for a much poorer cognitive outcome. And in thinking about then, what is the relationship between a mutation and an outcome? The idea that this kind of background could be so influential within the normal range. All of these parents are typically developing people, and that this variation within the normal range in genetic background has the power to determine what is the ultimate outcome of this particular deletion. So a really important concept. And this could be looked at for other attributes as well that include motor functioning, social functioning. This is the social responsiveness scale, and various measures of IQ. This is for 22q11.2 deletion patients, and looking at the what would be expected from on the basis of parental IQ scores in a unaffected population. And here would be the patients with those particular deletions. And this particular deletion is one that also raises risk for the condition of schizophrenia. And so the extent to which this particular slide depicts ways in which these different aspects of motor functioning, social functioning, cognitive functioning map to also the relationship of this particular deletion to causation in schizophrenia. And so one of the things that that is happening in current research then is for these kinds of experiments to be done. So within a network that includes researchers that are interested in the 22q11.2 deletion, which is a highly recurrent deletion in the population, the Genes to Mental Health Consortium of NIMH is now trying to replicate this work across multiple chromosomal rearrangements that are common, that are uniform in nature, and where we can start to understand, is this the same kind of relationship where genetic background for these different attributes will predict outcomes? Because imagine that from the time a child is born, being able to make predictions about outcome on the basis of family inherited genetic background indexed by quantitative traits of parents within the domain of interest is not only a very powerful predictor, but becomes a target for intervention to support children, early in development when these risks are apparent. And it becomes really important to ensure that that any attempt at supporting them and optimizing development and optimizing access to developmental therapy, which I'll talk about in a second, is very important. One more point I want to make about this is that in thinking about these distributions for patients with deletions and different types of genetic conditions, there are other kinds of conditions where background genetic effects may not make this kind of contribution at all. And I'm going to give an example. I didn't include a slide of it here, but in neurofibromatosis, it turns out that there are significantly disproportionate burdens for autism, for cognitive impairment, for ADHD. And in autism, and probably for ADHD, one of the fascinating things about prediction of those, maybe I'll stop there and maybe encourage everybody to mute their, thank you. So, so in neurofibromatosis, this particular relationship doesn't really hold. And what's fascinating about neurofibromatosis is that neurofibromatosis is always a haploinsufficiency syndrome that comes from loss of function of one allele of the neurofibromatosis gene. And it can be inherited in families. About half of the cases are actually inherited. One of the things that we learned from neurofibromatosis is that we saw the same kind of interclass correlation coefficient, not on the basis of who is your parent, but really on the basis of, do you have the exact same mutation? So in neurofibromatosis, even though all of the mutations for patients with the condition are functionally haploinsufficiency syndromes and a loss of function in one of the two copies, the literal position of the mutation was what determined the degree of co-occurring autism or ADHD impairment. And so you could compare the scores for these behavioral impairments of individuals that shared the exact same mutation. And even though everybody in the sample had a haploinsufficiency syndrome, and there were no correlations for their medical symptoms of neurofibromatosis, the correlation, if you were a relative within the same family, shared the exact same mutation, was on the order of 0.7. And that was published in JAMA Psychiatry a few years ago. But so it's the other principle to say is that probably not all mutations respond to background genetic variation in the same way. And some of the causes for comorbid psychopathology are going to be specific to different mutation types. But we have to learn about that. And the way to do that is to study these particular conditions in relation to familial genetic background when we can do that, and also in relation to specific mutation type. And I'll show that in a minute when we can do that. And so the next generation of studies, I'm getting a little ahead of myself, but advancing the field of understanding these relationships and therefore understanding biology and mechanisms and being able to make predictions and being able to target treatments and personalize approaches to the care of patients with these conditions depends on better understanding of these relationships. And here again, I'll just say one more time for this particular study. Imagine where we were 10 years ago when we thought, well, if you have a 22q11 1.2 deletion, you could end up with, we could tell a family, you could end up anywhere with a cognitive full-scale IQ between 40 and 100. But now, look at the level of precision by which we can make these kinds of predictions. And that level of precision should get better and better as we get more information on what are the determinants of these neuropsychological kinds of outcomes. Now, so that's one kind of modifier, background genetic variation. Now I'm going to talk about a second modifier, and this isn't in relation to a specific genetic syndrome, but it's so important that I wanted to bring it up today because, again, this is about autism in general. And let's just say that autism in general isn't about necessarily specifically about autism caused by a known genetic variant as a causal influence on autism, but so many of the cases are currently well over a third have at least some contribution from a measurable, identified molecular genetic variant that has been associated with developmental disability of some kind, or even autism in particular. Usually it's more general, that they're associated with more general neurodevelopmental disabilities. And I want to make the point here in this study. This is a plot from a 2018 Centers for Disease Control study that now has been replicated twice, which essentially shows the following: that if you have autism in the United States and you're white, non-Hispanic, the likelihood that you also have intellectual disability to go along with that autism is 20%. If you're Black, non-Hispanic, and you have autism, it's 50%. And this is one of the most profound health disparities that I can even imagine that influences developmental outcomes of the US population of children. And there were many excuses historically given for why this discrepancy might be true. Just the most common one was that if there are health disparities that result in lower identification rates for autism for Black non-Hispanic children, then of course the ones that are identified are going to be more severe, and therefore one might expect a higher proportion of intellectual disability. But what I'm here to tell you, and a lot of people, a lot of this happened during the pandemic, and maybe it didn't hit your radar screen, but essentially we are in the era where the case identification through clinical means throughout the population is equal for white non-Hispanic and Black non-Hispanic. And so that excuse or definition or reason for disproportionate rates of intellectual disability is no longer valid and is not a good excuse. And so what we did following the recognition of this disparity was to look at a large number of children, African-American children with autism, and try to identify potential correlates for intellectual disability comorbidity. And the study that we published was under the title Timing of the Diagnosis of Autism in African-American Children. We showed that there were great delays in diagnosis, that there were these excesses in intellectual disability comorbidity, but they were not explainable on the basis of some of the usual excuses. First and foremost, that there was under identification of Black youth with autism, but more prominently that the excuses of family income or other sociodemographic correlates of race in the United States were not adequate to explain this horrible disparity that 50% of the time, if you have autism and you're Black, you're going to have intellectual disability. And what we tried to point a spotlight on is that the most likely cause for that discrepancy is inadequate service access for developmental therapy and appropriate early education for children with autism. This paper was then editorialized in Journal Pediatrics by the title of a paper entitled Structural Racism and Autism, where these particular commentators believe that the data shed light on structural racism as a driver of inequity, and citing this idea that a third of the time parents cited availability of professionals as a barrier even to getting diagnosed, let alone service access, which was a major problem for the children that we brought into the study and that were representative of Black youth with autism in the United States. So when we responded to that, and this is very recent data, to just make another long story short, but by moving up the timing of diagnosis and delivering developmental therapy and judicious handoff to early education services for the kids in an open trial sample that should be published soon, even 5 hours a week of developmental therapy. The standard is 10 to 20, but even 5 hours a week of developmental therapy raised the full-scale IQ scores of these kids by about 7 points, even just with 9 months of that kind of intervention. And the opportunity is for years of that kind of intervention. So far, we are hopeful that there's going to be a pathway by which some of these disabilities that we see with genetic syndromes, genetically caused syndromes, the degree of impairment, not only psychiatric impairment, but literally cognitive impairment, could potentially be offset by modifiers that include judicious implementation of early therapies for these kids. So I have a lot of hope for that, and wanted to point out these particular phenomenon as a sort of a hopeful representation that there are ways that the severity of these syndromes can be headed off at the pass. And then a last point I want to make, I'll make it very briefly, and I think for the, because this is a genetics audience, is that it has become very clear from studying autism and in this particular group of studies that were sort of summarized in this paper, that if you take two genetic clones that have autism, it is remarkable how different the severity of their symptomatology can be. And the more severe the most severe twin is, the more variation there is between two identical twins for the severity of the condition, which is really remarkable. And so we showed this in a series of studies to point out that one of the signatures of neurodevelopmental impairment that is caused by genetic conditions looks like its vulnerability to stochastic influences that can begin very early in development, presumably in early brain development, potentially, over early childhood. One of the remarkable features of our studies of identical twins affected by autism was that there were no age effects on the differences in severity. Usually when you think about differences between identical twins, if they accumulate over time as the twins age up, you think about non-shared environmental influences that accumulate over the life of, a pair of identical individuals. But all of these effects were essentially fixed by the time the kids were 2 or 3 years of age, based on the ages in which we made these ascertainments for clinically affected identical twins. So stochastic influences are a signature of neurodevelopmental disability, and some of these differences in severity were profound. And they weren't on the basis of just instability of measurements. The measurements, the repeated measurements of an individual over years of time, we have the measurements, and they're rock stable, as shown in the kind of, this is a scatter plot of time 1, time 2 measurements that show the stability of the kind of measurements that these kids have. But in the upper plot here is how the difference in scores between a pair of clones of identical twins widens and widens and widens as the burden of the condition accumulates in terms of severity for one of the twins. So it's a very interesting phenomenon and described in this paper that really points to stochastic influence as a major player in modifying the effects of high impact deleterious variants on developmental outcomes. Okay, so I'm going to talk a little bit about what to do very briefly. So in the realm of clinical care, when a person has a developmental disability that is caused, let's say, by a known genetic variant, let's say intellectual disability or autism, and they also have a disabling behavioral impairment, such as aggressive behavior, anxiety, depression, substance use disorders, etc., psychosis, it becomes very difficult to get your hands on a literature that relates every neurodevelopmental disability condition with every possible psychiatric condition. If you took the combinatorial landscape of all the DSM-5 diagnoses with intellectual disability and autism, it would be impossible. But I just want to point out that there are interventions, and there is an evidence base that actually covers the comorbidity of a developmental disability with a behavioral disorder. There's a literature on developmental disorders and their care. There's a literature on behavioral conditions, obviously the entire psychiatric literature, but there actually exists a narrow literature of very good studies of what happens when you have both. And what we did as a group not too long ago was to cull that literature, because what's very important is to understand that most of the time, you can't just treat these conditions as if a person falls in one camp or the other when they truly have both. And I just want to point out that the domains of, and some of which you may never even have heard of before, but in the realm of developmental disabilities, positive behavior support strategies and applied behavior analysis-based strategies are very, very important, but they don't even hit the radar screen of people who are in particularly psychiatric kinds of treatment environments. And so when you have both, oftentimes a patient who has both gets relegated to one system or the other, and it's usually the developmental disability system, and they usually don't get the best of both worlds in treatment. And so typically a strategy for a person with a dual diagnosis includes a positive behavior support plan, a therapeutic intervention, a psychopharmacologic intervention, and dovetailing different aspects of care that are hopelessly fragmented in the community. So one of the things that we wanted to do was to cull the literature. And so this is a paper from February of 2020 that brings everybody up to date on actionable practice parameters for the treatment of dual diagnosis. And then we translated that into a clinical decision support app that you can get at the App Store or on Google Play. This is work that was done in Missouri with a group called the Missouri Alliance for Dual Diagnosis that was commissioned by the State of Missouri Department of Mental Health. And so I'll just say that for clinicians who are interested in what is the universe of intervention possibilities for a patient with a joint behavioral disorder and a developmental disability, this app takes you through recognition of the behavioral syndrome. What are the biological and medical factors that you have to think about? What are psychological and social factors that might be impinging on these manifestations in this patient? What are the factors that maybe relate to unresolved trauma? And then how do you devise a comprehensive intervention plan for addressing the behavioral problems of an individual with a developmental disability? And so people have been using this or going back to this compilation of the literature, but I offer that as a resource because there really are ways that patients can be helped. And when we ultimately sort of case conference dual diagnosis patients who are doing poorly, we see all kinds of lapses in really best practice for dovetailing those kinds of interventions. And often see manifestations of fragmentation of service systems that are trying to help them, to the extent of not even knowing what a person's history was in the last place that they stayed or the last clinic that they went to. And so the problem in dual diagnosis is such an amplification of fragmentation of care, and really people not being knowledgeable about what evidence-based psychiatric and mental health interventions are actually could be put in play to help a person with these conditions. Okay, finally, advancing science. I'll be quick about it. One of the difficulties with advancing science in this area, I think, as everybody on this call knows, is the escalation of, there's lots of variants of uncertain significance. I wouldn't say it's the cause of a gap in knowledge. It's a reflection of there's a lot that we don't know. And so how are we going to get our minds around what is the association between genotype and phenotype? And everybody knows the answer to that. We've got to have more patients that are characterized both ways in a standardized way and not clinically ascertained just for one condition, but across all of medicine, to think about when we see a variant, how does that relate, through clinical testing and certainly through research testing also. But oftentimes research testing is so highly ascertained for a specific diagnosis that it violates a lot of epidemiologic principles about how are we relating genotype to phenotype. So at WashU and with all of the sites of the NICHD Kennedy Centers, we are in the middle of the development of a national brain gene registry that is trying to link clinically acquired genetic results with reasonable, not perfect, reasonable neurodevelopmental phenotyping, either that is within the electronic health records and can be extracted, or that can be superimposed by just rapid virtual assessments that are standardized, and they could be deployed in clinical systems that are using electronic health records, and for which electronic health records could help guide nurses, master's level people and parents of incorporating important neurobehavioral indices of developmental status, and co-registering a clinical genetic test with electronic health record data that relates to neurodevelopmental outcome and standardized neurobehavioral assessment. And that's what the goal of this registry is. And so far, it's off to a great start. It is connected with ClinGen and ClinVar, the National Institutes of Health's strategy for co-registering genotype and phenotype for the purpose of accumulating cases. This is a great example of what you can do when you accumulate enough cases of people with a certain genotype and know enough about their phenotypes to start to do what I talked about with neurofibromatosis before, which is to draw the lines between, what can we predict about a specific genetic variant within a family of conditions. And what we learned in the early going of the development of the National Brain Gene Registry is that when we harvest information out of the medical records of the electronic health record system of these 13 academic medical centers that are in the IDDRC, Intellectual and Developmental Disabilities Research Center network of NICHD, these are over 470 variants in putative brain genes that have not yet been curated by NIH, but there's some thought that these might be brain genes or have a role in brain development, and any loss of function mutation is usually tagged as a variant of uncertain significance. And we just asked the question, if we harvested variants in those genes from the electronic health records of these 13 sites, how many of them actually already existed in ClinVar? And only half of them had been uploaded to ClinVar. They're sitting in electronic health record systems all over the country with no correlating phenotypic data, and they're not in ClinVar. And so we cross-reference all the other databases as well. And basically, most of what we could get just out of saying, if you're a patient in an electronic health record system who has a variant in a putative brain gene that hasn't yet been curated, and we don't know what the effect of a loss of function mutation is, half the time for ClinVar and 95% of the time for all the other databases, that variant has not been posted. So we have an opportunity, and that's just the first pass at a small number of putative brain genes. I think it was from a pool of, the first one was from a pool of about 55. And so this manuscript is in preparation. I'm going to stop there. I think that's the strategy, that we need to work together to populate these registries. I talked about the Brain Gene Registry. These are the folks from Washington U, Chris Cornett, Dustin Baldridge, and Philip Payne, who's been at the helm of that, Maya Chopra at Harvard as well. I talked about the Missouri Alliance for Dual Diagnosis, and I talked about Genes to Mental Health. Krista Martin and David Ledbetter are very close colleagues working on that project that's trying to relate. The Brain Gene Registry is really related to variants and uncertain significance in specific genes. And Genes to Mental Health is really about recurrent copy number variations, doing the same kind of thing of really registering associations between genotype and phenotype. Okay, I will stop there.
What a wonderful lecture. Thank you, thank you, thank you so much, John. I know I do want to announce that we have taped this lecture. It will be available on SERN for your colleagues who couldn't be here and hear this wonderful lecture. Please send them. And I will open up for discussion. Hans, if you'll join me to lead the discussion for next few minutes, I would appreciate that.
Sure, I'd be happy to. Are there any other questions from the audience? So, John, what I was thinking about when you showed that 22q11 deletion paper with the effect of intellect from the parents on the child is how clear that message is that neurological function and behavior are polygenic events.
Mm-hmm.
And, you know, we continue for methodological and technical limitations to think in a monogenic perspective. And your talk has been so clearly that this is a global neurological issue that it will take us, unfortunately, many years to fill in the empty spaces. But you know, I guess epilepsy would also come into a close proximity to risk factors for behavior, ADHD, autism spectrum. And I wonder if you have anything to say about polygenic risk scores and approaches to that really important.
Well, I mean, I'm at the edge of my seat for the day when polygenic risk scores can capture enough variance to, you know, give us a lot of, you know, predictive power, and they're getting there slowly. I think one of the reasons it's so slow is that the ways in which we identify polygenic risk scores is that we compare people with a disease to people who don't have that disease. But the people that don't have that disease actually have subtle endophenotypic liabilities that don't quite reach the threshold for disease, but they have some of it too. And so if we aren't measuring, especially for autism, the carriage of those developmental contributors, even in the control population, we really erode the signal for a polygenic risk signal. So I think some of those studies are going to need to be redone and reconceptualized to get a higher proportion of variance explained. And then my last thing is what I tell all the residents when they ask me about the residents and students about polygenic risk scores. and or the early career investigators, and I say, I'll tell you what I'd rather have than a polygenic risk score, a family history, a family psychiatric history.
Yeah,
And,
yeah.
and the family history of the parental IQ is such a great example of a phenotype within the family is a powerful predictor, and it actually outstrips the predictive power of most polygenic risk scores for most psychiatric conditions, and yet we don't use it, and we're still dashing ourselves against the rocks for more polygenic risk scores.
Yeah.
And we have to do it because that's the biology. But that's another talk for another day. But I think family history is very powerful and a very important part of precision medicine. And here, just a incredible kind of demonstration of how that actually works.
What do you think about the limitation of family history in not being able to distinguish nature from nurture? A lot of behavior is, epiphenomenon related to environmental et al. And a family history doesn't help us clean that up so well.
I think that's where we have to, Hans, I think it's a great point, but if you actually look at the phenotypes that you're indexing by family history and challenge yourself, whether it's a family history of ADHD or a family history of schizophrenia or a family history of alcohol use, and you ask yourself in a classic twin study, what is the proportion of variance accounted for by common genetic influence just by looking at identical and non-identical twin concordances? We're very hard pressed in psychiatry to see a really strong influence of the common environment for many of our conditions, not all of them. Some of them, there's lots of, common environment. But but we can take a page out of the genetic epidemiology playbook and say, if we want to clean up our understanding of family history, just pick the ones that we know. That the heritability, additive genetic influence on this particular quantitative trait is so high that when we're indexing it, we're indexing something that really is giving us a window on polygenic risk. And that's why I think IQ works so well in that way too.
Yeah, I think those are great points.
John, I have to say, as a nutritionist sitting here, I'd love to see you. I've mentioned this to you, to see I get very fascinated by the impact of nutrition and brain health in general. I'd love to see us add that component. I know with the studies you've done, we assume it'll be the same diet and things, but the spectrum, what it can contribute towards mitigating and also influencing some of this would be lovely.
Well, Ronnie, as you know, the best pathway to identify in a precise way the influence of environment is to fix and hold constant what we know about genetic contribution. And so as we're getting our arms around the variants, we get better and better at being able to understand what the rest of those contributing factors are. And it literally increases our statistical power by reducing noise to identify those kind of effects. And I think that needs to be the next generation of studies.
Yeah.
But like I said, I think they need to be designed carefully so that, when we call somebody a control, are we measuring the same contributing factors in the controls as we are, in the cases, and really thinking carefully about study design.
This is excellent. It's amazing. So much food for thought. I know we're running out of time. Unless somebody has a real burning quick question.
We do
I have to make
one
room. I have to make room for my friend Zora.
Yeah, we have one question.
It's
Yeah.
blabbed on and on, so people should feel free to go. But I got to make room for Zora.
Thank you so much, John. It's great to see you. Thank you.
You too.
Fascinating presentation as always. And thanks, Ronnie, for organizing this and for letting me know about this. I just wanted to know, do you have any any suggestion moving forward, how to look into gender differences? Because of course, we know the complexity of the genetic landscape and also epigenetic, as you briefly mentioned about that. But moving forward, how can we look into the gender differences considering the complexity of the situation?
It's wonderful. I absolutely wish I had time. I think one of the profound implications of the last 20 years of research on autism is that everybody expected it to be X-linked, like the X-linked intellectual disabilities, because of the massive, sex ratio for autism, and almost none of the identified molecular genetic burden is on the X chromosome. And it's fooled everybody. And it fooled me for a while too, because we thought, well, maybe this is because, females are protected, from autism, but it turns out that it's much more complicated than that. We just published a study in Neuron that examines all of the latest data and the latest kind of, hypotheses around what would cause the sex difference in autism. And I'd love to refer everybody to that as well. And we still don't know, but we're narrowing the playing field. And some of the things that everybody thought might be true have really been falsified. And so it's really an exciting time and an important time to understand how sex has these effects. Clearly, it's one of the most profound modifiers. And what I will say too, one of the things that's been interesting, I didn't talk about this, but in autism, the sex ratio for a lot of the more severe autism syndromes that are typically caused by highly deleterious variants or influenced by highly deleterious variants, the sex ratio narrows to 1-to-1, basically. This was discovered, by Judith Miles at the University of Missouri years ago in observations of her, early genetic, disorders clinic. So there's something about how polygenic risk, or the lighter kinds of genetic liability, are more influenced by sex or more modified by sex, and understanding how that all plays out is going to be really, really important, because clearly the burden is so much higher for males and females, and it's apparent by the time babies are literally 2 years old. When you take a look at the high-risk infant sibling studies, that 3-to-1 or 4-to-1 ratio is present at age 2, which is absolutely stunning, long before puberty and the usual influences of sex. So much more to follow on that. But if you want to look at a reference for where we are on that in autism, and I don't take credit for it, I was one small part of the group. It is a spectacular group of people that took all the data, funneled it into all the hypotheses, and said, where are we, with understanding this? And this group is also moving on with a new, kind of frontier of studies that relates to what we already know. And let's go to the next step. But it's such an important question.
Thank you so much.
Yep.
Well, thank you so much. Teresa probably got Teresa, you can close. I apologize.
I'm still here. So I posted the link to the post-test in chat, and I will also send out an email to everyone just in case you didn't get the link. And if you want a certificate of completion, it will be sent to you within the next few weeks as well. So we will send an email once the video is online for recording, especially if you have colleagues that weren't able to attend today. So thank you all. And
Thank you,
Thank you,
John,
everybody.
again for a
you.
fantastic. I wish we had more time, but thank you.
Thanks, Ronnie.
Just
Thank
do it
Take care,
again.
everyone.
Yeah, thank you. Yes.